Hi guys, this is Dr. Christina Kass Illeya. I'm working with my PI, Dr. Kimberly Jones Rudolph, on my project, which is a literature review. It's about the significance of cone beam computed tomography in orthodontics, which is a comprehensive evaluation of accuracy and integration in Invisalign treatment planning and recommendations for future research. Overview. So efforts have been made to enhance diagnostic methods and their application in serving orthodontic patients. Notably, the integration of CBCT into Invisalign's ClinCheck has elevated imaging capabilities to a new level. This innovative feature empowers orthodontists to visualize predicted movements in 3 dimensions while also detecting changes in both hard and soft tissue. However, these advancements have brought to light significant challenges. For orthodontists to take advantage of this innovation, they need to know if the presence of dehiscence and fenestrations, as shown by the CBCT integrated ClinCheck, are in fact likely and therefore necessitate modifications in treatment. Some ideas that we got from our background check. We compared the CBCT versus other radiographic modalities in periodontal defects assessments. And we found that compared with the direct measurements, the CBCT were the closest to the control group or the direct measurements. The image accuracy produces images with sub-millimeter isotropic voxel resolution from 0.4 milli to as low as 0.076 milli. The star P seems to have little effect on the periodontium when measured clinically. However, the CBCT demonstrated some statistically significant changes. The Mullen et al. Highlighted the critical factors when designing CBCT studies, which were the image qualities, bone biology, and statistical aspects. And the bony defects, craters, and deforcation involvement seem to be better depicted on CBCT, while the bone quality and periodontal ligament space scored better on conventional intraoral radiography. The objectives of my paper first is to understand the accuracy and limitations of CBCT when integrated in ClinCheck software and its effects on orthodontic treatment planning. And the second is to understand the ClinCheck predictability and the movements that are likely to cause dehiscence on fenestrations. So for my materials and methods, we did a search in PubMed and Google Scholar from January 2010 to March 2023. To find studies related to CBCT and ClinCheck in orthodontics. And we used the mesh terms CBCT accuracy, CBCT predictability, ClinCheck predictability, ClinCheck accuracy, alveolar buccal defects, CBCT, and dehiscence and fenestrations. We came up with 389 articles were potentially relevant. After reviewing the summaries and full text of those articles, only 12 were deemed suitable for inclusion in the literature review. So our inclusion criteria was prospective and retrospective original studies on humans or cadavers with permanent dentitions. We also included the case series. Also the studies on orthodontic treatment with clear aligners. The studies that included clear description of the materials and applied technique. And the studies on CBCT accuracy in detecting fenestrations and dehiscence. We excluded the animal studies, the reviews, and the studies on patients with genetic syndromes and several facial malformations. Basically, here we will find a table of all the studies that were included about the CBCT accuracy, especially its accuracy in detecting dehiscence and fenestrations. We will start with Benya et al. In 2015, which was a prospective study. It had 18 patients. Their voxel size was 0.3 millimeter. They compared the accuracy of pre-surgical CBCT measurements with direct measurements on labial and palatal bone. And they came up with these results that we can see here on the side. Teneka et al. At 2021 had an observational study that did on 5 cadavers, and his voxel size was 0.25. His measurements were made on CBCT for buccal thickness at 3, 5, and 7 milli, and he compared those with the measurements made histologically at 3, 5, and 7 milli. And he found that the CBCT significantly overestimated the buccal thickness, and here we will find the difference between the CBCT and the histological measurements. Next, we will move to Alcino et al., which had a prospective study, and they included 16 patients with a voxel size of 0.25. They compared the measurements of fenestrations and dehiscence on CBCT with the measurements that were doing clinically during a surgical procedure called AAO. And they found that there was statistically significant difference, and the dehiscence in CBCT and fenestrations were overestimated versus the direct measurements. Next, we have this Sun et al., which also had a prospective study. He included 18 patients, and the voxel size was 0.125. He compared the measurements of fenestrations and dehiscence on CBCT with the clinical measurements during the AAO as well. And he found that the sensitivity and specificity of CBCT for dehiscence and fenestrations were over 0.7 milli. We also included a study about Jiang et al., which was a prospective study. They included 69 patients. Their voxel size ranged from 0.2 to 0.3 milli. They compared the accuracy of integrated models in identifying dehiscence and fenestrations versus the measurements from post-treatment CBCT. And they found that the molar distalization and proclination were positively correlated with significant increase in alveolar defects at the mandibular incisors after treatment. Then we have Walter et al. In 2010, also had a prospective clinical study, 14 patients, and the voxel size was 0.08 to 0.25 milli. He compared the accuracy of CBCT in assessing maxillary molars furcation involvement with intrasurgical measurements of furcation involvement. And he found that overall 84% of the CBCT data were confirmed by the intrasurgical finding, which indicates a high degree of accuracy. Next, we will look at Kiao et al. In 2015, which was a prospective study, voxel size of 0.25, also compared accuracy of CBCT in assessing maxillary molars furcation involvement with intrasurgical measurements. And he found that the intrasurgical findings confirmed 82.4% of the CBCT data. While Tonisin et al. In 2015 had a clinical trial with 64 patients and voxel size of 0.08 milli. He looked at the sensitivity and specificity of CBCT in thin bony structures in maxillofacial surgery, and he came up with those results. We also came up with 4 more articles about the ClinCheck predictability for the movements that we have in orthodontics. And we found Krieger et al. In 2012, Dye et al. In 2021, Teen et al. In 2023, and Rossini et al., which had a systematic review in 2015. So in our discussion, we found that these reviews mainly looked at the dehiscence and fenestrations detected using CBCT. And the study by Kiao et al. And Walter et al. Compared furcation involvement measurements from CBCT with intrasurgical measurements and found high agreement between both modalities. And the results of Alcino et al. And Sun et al. Reported an overestimation of CBCT when compared with intrasurgical measurements. And they both reported a high sensitivity and specificity for CBCT. So in conclusion, there is significant need for a rigorous study on CBCT accuracy. And for ClinCheck, the predictability of ClinCheck in predicting various dental movements generally displays promising outcomes. The CBCT has an overestimation of dehiscence and fenestrations. And when we look at the minimum bone thickness and orthodontic planning, the orthodontic practitioners typically require a minimum bone thickness of 1 milli to facilitate tooth movement effectively. And if the thickness is not discernible in CBCT, that indicates that it's less than 1 milli. Also, for Invisalign movements and potential overcorrection, in cases involving Invisalign treatments, it's noteworthy that achieving predicted movements might demand overcorrection in numerous instances and necessitate the utilization of auxiliaries to attain the anticipated outcomes. And here are my references. Thank you.